Hello, and welcome to this week's edition of Let's Talk SADS Live Canada. I'm your host, Dr.Shubhayan Sanatani, and I'm coming to you from Vancouver, British Columbia, where it's 9 o'clock in the morning, and excited to be joining you again this month as summer feels like it's winding down a little bit. There's been that back to school chill in the air, and very excited today for another great guest. So let me just get things a little bit set up here. Big thank you to our partners in our SADS Live venture, the American SADS Foundation, and Alice Lara and Aaron Waite are instrumental in us being here today. So we really appreciate them. And of course, now are my slides up. There's my slides. An exciting topic today, getting back in the game, sports and exercise participation. So more on that in a moment. And want to thank some of our sponsors here, Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, and Thrive Therapeutics. It's a really exciting time for healthcare providers and also for patients with SADS conditions, sudden arrhythmia death syndromes conditions. So these conditions that are thankfully relatively rare, but can cause sudden and unexpected cardiac arrest or even sudden death, often in young, otherwise seemingly healthy individuals. So that is really what we focus on here at the Canadian SADS Foundation. And we're excited to be partnered with some industries that are really, breaking the barriers in treatment. And so these companies are doing exciting things. We've talked to some of them about gene therapy and new medicines that are all being tested on these conditions. So the treatment is really changing. And we really depend on sponsorship to host this webinar, to provide educational content, our webcast. And we are also doing some CME, continuing medical education style talks where we have an expert or two join. So lots of education for our patients and our care providers, and all thanks to our executive director, Pam Husband, and the board who have really been driving this as we reemerge from the pandemic and quieter times. So we're even hoping to do some things like maybe get together in person sometime. We know our SADS colleagues in the States are having a meeting in November in Chicago, so that looks very exciting, and I'm sure some of us will be there. You probably know I like to add a little fun fact, and I'm just going to flick through some of our past ones. For those who are viewers from last year, you know that at the end of the year we had a little trivia contest, and someone won a gift certificate, and so you might have to pay attention. Now, I know some of you watch these episodes later in the quiet of your home, and so you could even take some notes on our fun facts. Last month we talked about the autonomic nervous system, which of course is so important in controlling the heart rhythm, and is an important component of exercise. So today I wanted to share with you something that I found in my readings. A fairly old paper, 1961, so over 62 years ago, 63 years ago. And this is a Canadian paper from Montreal. And you'll see the title is Hereditary Cardiovascular Dysplasia. And we've talked in the past about arrhythmogenic cardiomyopathy, and it was initially arrhythmogenic right ventricular dysplasia. So here is a form of familial cardiomyopathy. And what they were talking about actually is what we now know as hypertrophic cardiomyopathy. And back then they were still learning about this condition, why these patients had very, very thick hearts in the absence of any known cause. So they didn't have high blood pressure or other reasons for having these very thick muscle. And you can see a cartoon there of how they drew the thick middle portion especially. And of course, now we know this as hypertrophic cardiomyopathy, but this was a seminal paper at the time and went back hundreds of years because they had several generations of this family and 77 family members with almost a third of them affected. And many of them died suddenly. And of course, we now know, of course, that hypertrophic cardiomyopathy is one of the most common causes of cardiac arrest in athletes. And so with that, I will introduce our guest. I'm very excited to bring Dr. Nathaniel Moulson, and I will revert to calling him Nate because I've known him since he was a trainee here at UBC. He is a cardiologist, a sports cardiologist who is very well trained. He is Preventative and Sports Cardiologist at UBC and is the medical director of the Vancouver General Hospital Cardiac Rehabilitation Program and CardioRisk Prevention Clinic. He also is a clinician investigator at the Cardiovascular Innovation Institute and is very involved in multiple research studies in the area of sports cardiology, with a real focus also on getting data on activity participation. And so let's bring Dr. Moulson into the studio and get him to educate us on some of these great things that he's working on. Dr. Moulson, welcome. I will probably slip into calling you Nate, although it's wonderful to have you join here this morning. Thank you.
Well, very nice to see you, and thanks so much for the opportunity, and thanks to SADS Canada for putting on these great webinars. I'm really happy to be here to talk on Let's Talk SADS Live Canada. Thank you.
And I like to sort of help our audience understand a little bit about who we're talking to today, and so tell us a bit about your journey. How did you become to be a sports cardiologist? When did you sort of know that was where you were heading, and how did you get there?
Yeah, no, it's a great question. And sports cardiology is still an area that's really in its infancy in Canada. I will say there's not many of my colleagues, or when I told them I was interested in this, were like, oh yeah, that makes sense. They were more along the lines of, you can actually do that as a career, and that's something that you can find training in. So I think it was a little bit of an atypical path, if you will, but I think we're starting to gain momentum and kind of critical mass in Canada, and definitely the US is ahead of us in this regard around identifying the need for sports cardiology specific training to help care for athletes with cardiovascular conditions. And so my specific journey, I was actually an exercise physiologist prior to going to medical school, and I like to say a failed athlete. And so wanted to kind of remain around sports and exercise, and really was always fascinated by the interaction of high volume exercise stressor on the body and how we adapt to that, and how actually we're kind of made to adapt to that, and particularly the heart and the cardiovascular system. And so with that in mind, as I was going through my medical training, just kind of thought, it would be really interesting to continue to look at, what are the effects on patients with cardiovascular disease? Because we know that exercise is so beneficial across, physical and mental health. But I started to recognize, that there was these, areas where, telling patients, maybe you shouldn't exercise, or maybe there's danger associated with exercise. And not to say that that can't be true, but I think there was a lot of, at the time when I was going through, a lot of these articles published around opinion and controversy around, particularly around a higher intensity exercise and competitive athletes. Should they continue to play? Should they not? Where does the decisions, and really a lack of data in this area. So that kind of all piqued my interest in it. And I was fortunate enough to be able to find some mentors that were really in this space, and kind of pushed me in the direction of kind of pursuing the sports and exercise cardiology. And I really, as I went through though, decided to pair it with cardiac rehabilitation and cardiac prevention. I think they pair nicely together, especially in the adult cardiology world, at least, as we're dealing with, how do we exercise patients after they've had, very significant cardiac events, whether that be a heart attack or a cardiac arrest or even a cardiac transplant, and how do we get them back to doing, even if it's not competing, at the level of the athletes we're talking about today, but performing physical activity and exercise for health and wellness benefits, and really to help them kind of get back and integrate in the lives that they had before these events occurring. And then it kind of pushes to the kind of the other end of the spectrum. I like to say I care for, and look after cardiovascular patients across the spectrum of exercise and cardiovascular disease. And so talking about younger patients, I know that's your area of expertise and focus as well in the pediatric world. And they see a lot more kind of in their late teens, early 20s that have a kind of a different, and that's, the SADS conditions are the, quintessential example of that. Those conditions that maybe increase the risk to some degree of a sudden cardiac event, particularly sudden cardiac arrest or severe outcomes such as that. But otherwise, the patients can participate in sports and don't really have the same limitations we see with more severe, heart failure or heart disease patients. And that's the area I think we're going to focus on today. It has its own set of challenges, and really one that interested me around how do we help support patients with these conditions to make appropriate and informed decisions about their choices to continue to participate in sport, to do it in a safe manner, and where the data and the evidence lie in that regard.
Yeah, no, there's so many areas that your discipline of sports cardiology and rehab branch into. And so, yeah, we'll sort of focus on our area here, the SADS, the sudden arrhythmia death syndromes conditions, and including the cardiomyopathies. We would be remiss not to give a shout out to our good friend and mutual mentor, Saul Isero, who's done so much work in this space in British Columbia, and several others. I mean, we've been fortunate in BC that there's been a real appetite for exercise physiology and sports cardiology. You, of course, you've been working with some of the very few huge names in the field, John Dresner and Aaron Bagish and a few others. So it is a relatively new field that's gaining traction. Even in the short time of your training, you've probably seen quite an evolution in terms of we used to not even worry about too much exercise. So we've seen a real shift in that. But take us back a bit. When did we first start worrying about exercise at all? Like, when did people say, "Oh, hold on a minute here, this might be dangerous for some people"? How far back does that go even?
Yeah, I won't spend too much time, because I love the history, and I know that you do as well from these aspects. But I start a lot of my presentations and discussions around exercise and cardiovascular disease with the concept of, we used to actually put patients that had traditional kind of acquired heart disease like heart attacks on bed rest. And one of the earliest interventions, if you really even call it exercise, was putting them into a chair within the critical care units and then mobilizing them early, and had significant mortality benefits along that. And then we started to recognize that, and the kind of the fathers of cardiac rehab and exercise saying, we should really treat our patients that have had heart disease, such as someone who's had physical ailments, such as those that are coming back from the wars at those times. And so they created this concept of cardiac rehabilitation. And then fast forward a few years, now back actually 30 to 40 years. And then it kind of switched a little bit as we're starting to exercise these patients that have acquired heart disease, to the kind of seminal papers recognizing that young people with no other overt symptoms or other issues at the time that they were aware of could suffer severe outcomes such as sudden cardiac arrest. And this could happen during sports and exercise. And so it was with that, and I think that starting off with a lot of the autopsy studies, so looking at those patients that had unfortunately passed away, that started to recognize that, in younger patients, so I'll use young here within the cardiology world, we talk about less than 35 is considered kind of the young competitive athlete, and those over 35 being more in the masters realm, And some of that has to do with when we kind of mostly have inherited or genetic causes of sudden cardiac death versus when the kind of uptick in acquired conditions such as cardiovascular coronary artery disease. But in that younger population, those studies started to show that there was, in a significant proportion of cases, an underlying cardiac pathology that could be identified that was felt to have, or shown to have, contributed to those sudden cardiac arrests. And so a lot of well-meaning physicians at that time with that data said, you know what, maybe if we can look to identify, or if we have identified these patients that have these conditions that we seem to think or know are associated with sudden cardiac arrest during sport, if we tell them not to do sports and exercise, particularly at high intensity or competitive levels, then that should, and there was a should at the time because there wasn't a lot of data looking at that, prevent the risk of those events occurring. And so it became more of a kind of protective approach to saying, we're going to identify these patients if we can, and then we're going to tell them that, that they don't participate in these vigorous or high intensity competitive sports, they're going to not suffer these kind of severe consequences, such as sudden cardiac arrest. Now, obviously that, that's, I think, the thinking at the time, and that's taken a long time to kind of change that thought process around how we approach or manage these patients. And I think over time, there's kind of been a few key observations that have really led to, people questioning and saying, is that really the right approach for our patients? The first, I think one of the big ones is the fact that as we get better at detecting disease, screening families, start to recognize that, these conditions are actually relatively prevalent in the population. So a lot of the SADS conditions and cardiomyopathies, hypertrophic cardiomyopathy, for example, can have a prevalence up to 1 in 250, 1 in 300 in the population. And thankfully, our kind of more contemporary estimates of how, like, the incidence of sudden cardiac arrest in young competitive athletes is more in the range of 1 in 50,000 to over 1 in 100,000. So not that they don't occur, just that they're not as frequent, I think, as initially or estimated, or concerns around that might show when you have, very high profile events happen in the media and everyone gets very concerned that this, could happen to, many other athletes, and that generates some, appropriate concern around the topic. But I think it's also important to take a step back and say that when we're talking about sudden cardiac arrest in younger competitive athletes, those are relatively rare events, and that the prevalence of conditions that may predispose someone to that are much more common. And so, undoubtedly, we've had many patients who haven't known that they have the conditions, or maybe haven't brought that to the attention of their care providers for various reasons, that have participated in sports and have been able to do so without any adverse outcomes. Now, that's not to promote that, avoiding telling your care provider around that by any means, but just to kind of show that that's the kind of observation over time that has helped to shift the thought process around that. And then on top of that, the other two things that I think are important here is that, as you well know, and I think many people on the call will know, that these diseases are not kind of a black and white. They exist along a spectrum from mild forms to very severe forms. And some patients may have very severe forms of, specific conditions that, would actually put them at a prohibitive risk for participating in vigorous intensity sport. But I would say our understanding, at least from observational data over time, is that that's actually probably the minor component to the disease, versus the majority of the patients may be able to participate in a safe manner without really being at, a prohibitive level of increased risk. And I think lastly, I think we'll talk maybe a little bit more about that as well, in terms of, how do we manage these patients, is an understanding of the patient autonomy and respect for kind of patients' values, and the fact that restricting somebody from vigorous intensity sport and exercise, particularly if it's a large part of their identity or for any, various number of other reasons, does have consequences, and they can be, significant. I think we didn't really, as a medical field, I say that, take that into account or weigh that as a significant factor, or as significant a factor as it should be, until more recently with the kind of advent and moving towards the shared decision-making model when managing these type of patients.
Yeah, so let's come back to that. You've covered a lot, and I want to just help our audience sort of, crystallize some of these very big concept. So, I think that most of these conditions, hypertrophic cardiomyopathy, long QT syndrome, Brugada syndrome, the first reports really were about fairly severely affected individuals, and then exactly as you say, the prevalence has gone up, so they've become more common. Long QT is now 1 in 2,000, and maybe that's even dated information. Hypertrophic cardiomyopathy 1 in 250 to 300. So these things are much more common, and there's far more people who are living with the conditions who do not have cardiac arrest. So it's important for our audience to sort of understand that. And so understandably 30, 40 years ago, and I'm remiss in not knowing what year the first Bethesda conference was, but that those first guideline documents, people were very restrictive. And our good friend and supporter Michael Ackerman famously always shows the chart showing crickets and billiards and rifflery as being sanctioned activities, again with no data, because I think we don't actually know about the strain or the stress in some of those those activities. So fast forward now, and we've started shifting our view. So tell us a little bit about some of the data that has been coming out in the space of the safety of exercise, because I know you're involved in a very big undertaking as well, the ORCCA registry that I want to talk about.
Yeah, and so I think underpinning a lot of exactly what you said is this idea that there's the ability, or that there's a lot more patients than I think we initially appreciated living with these conditions and living well, participating in sports. And so I think that was the impetus for some larger kind of really landmark observational studies that have recently been published. And I know you were involved in one of the LIV studies, the LIV long QT syndrome and the LIV HCM study as well. So these studies were run actually out of the primary author, Rachel Lampert from Yale, looking at observing patients with these conditions over a set period of time that participated in varying levels of sport and exercise. And not to get into too much detail about the individual studies, but I think just safe to say is that the kind of key observation in those two specific populations, talking about long QT syndrome and hypertrophic cardiomyopathy, was that there was not a significant difference in the risk of sudden cardiac event, sudden cardiac arrest for those that were participating in vigorous intensity or competitive sport compared to those that were participating in non-vigorous sport and exercise or sedentary. And so I think there's obviously, and I think we could spend some time going into that, but at another time, limitations in observational data. And I think one of the take-homes that I always say to my patients when describing this, or to others, is that observational data does have its limitations, and it's not to say that there's no risk associated with these conditions, and we well know that, but that the risk from vigorous and competitive sport and exercise seems to be a lower degree of magnitude than I think we had initially appreciated, and that there is also risk outside of sports and exercise as well. And so that eliminating participating in competitive sports and vigorous exercise does not eliminate risk entirely, and may actually not be necessary to kind of have any significant reduction in overall risk for a significant proportion of our patients. And so that requires, now there's, as you can see with the way I'm wording this, there's quite a bit of still uncertainty around the precision on an individual patient level to say, okay, what is, X, this patient in your room, and say when having those discussions, what is, they will always get asked, what is my risk if I continue to participate in this versus if I don't? And those are very challenging questions to answer, but I lean on the observational data that does exist to kind of help frame that a little bit for patients that kind of fit within those studies. There's still a lot of work to be done in a lot of other patient populations, though.
Yeah, and I think it's nice that people are gathering data, and and Rachel Lampert and her, she's very inclusive. She started also the safety of doing sports with defibrillators, which of course are implanted devices that many of our patients end up with SADS conditions, and good to know that there was no real signal. So it is reassuring that there's not an obvious signal that these, the more active populations are not, they're not at higher risk. Again, Mike Ackerman's done some nice work in long QT and in CPVT, and very few events. So it's a bit of a disconnect, because we've come from a time where most of the physicians were being told, really, restrict your patients, walking is fine, but everything else is dangerous. And now we're seeing, well, maybe that's not quite the case, and I think it's it's allowing us to have those individual conversations. And so you mentioned shared decision making, and I do want to come back to that, but before that, can you tell us a bit about the ORCCA study, just because I think several of our families would be interested in potentially getting involved in this?
Yeah, absolutely. And so I think the next step that we have taken in terms of collecting further observational data, specifically around the young competitive athlete population, is this study that I'm involved in, actually leading here the Canadian arm, with the principal investigators. I think you mentioned a couple of the names: John Dresner, Kim Harmon from the University of Washington, and Aaron Bagish from Boston at Harvard and MGH. So they're the leads for the study overall. And then I've been working on to make sure that we can enroll Canadian athletes to participate in this. And then now we are actually through UBC and can enroll patients from across Canada. And so the ORCCA stands for the Outcomes Registry for Cardiovascular Conditions in Athletes. It's focused on young competitive athletes, so they're ranging from 14 to 35, and competitive defined as participating in a sporting team or sporting event in a competitive fashion. So it has to be at the high school, university, professional or national or club or competitive club level. And we're looking at a wide range of cardiovascular conditions. So this is attempting to look at more of taking the competitive athlete, and then with any cardiovascular condition that we feel is at a potential increased risk of sudden cardiac event with exercise. And additionally, looking at borderline conditions. So those that we may not have data on, understanding whether or not there is a risk here, but we think there might be a potential. So an example of that is someone who is genotype positive, so meaning they carry the gene for a specific condition like hypertrophic cardiomyopathy, but they haven't either manifested any disease, and we don't know whether they will, and following those patients over time as well. And it also includes those that have findings on cardiac testing, such as imaging of the heart, ultrasounds, or MRI, that we consider borderline. So some of the time, and actually not some of the time, in many cases, we are left looking at images and saying, well, there was some abnormalities in testing, whether it was done through screening or because of some other reason. And we're not sure if those abnormalities are specifically a disease or not at this time. And so there's a whole list of kind of borderline conditions as well, some borderline thickening of the heart, abnormal electrical tracings, known as abnormal ECGs, and those type of abnormalities that we've all kind of think that there might be some future risk, or there is risk, and we don't really know. So we're including those patients as well. And the nice thing about the way that this study is set up, that it can actually be a patient level referral. And so by that, I mean, you can go to the ORCCA study website, orccastudy.org, and you can actually put in your information on there if you are a competitive athlete with a cardiovascular condition. And then someone from the study team will contact you, ask for some information and consent, obviously, for the study, and then can determine whether or not you might be eligible to participate in the study. And the study is an observational study, so we're just looking at collecting information around the condition, around the process that you underwent for shared decision making, determining, whether or not a decision was made to continue to participate sport, to not participate with sport, and how that was done and why that was done. And then following for the next, at least 5 years at this point, potentially longer, just to see, what the evolution is, in terms of both sporting career, as well as changes in disease and also cardiovascular events, including sudden cardiac arrest.
And I mean, it's a great undertaking, and hopefully can be sustained for beyond the 5 years, because of course these outcomes are infrequent. So if we're talking 1 in 50,000 or 1 in 100,000, we need a lot of people for a number of years to really start identifying groups. I like to ask you a challenging question. Most of these individuals that present with an event and may be diagnosed afterwards with cardiomyopathy or long QT, they've done exercise hundreds of times before. Do you have any sort of theories, particularly maybe as an exercise physiologist, why on one day do they suddenly have an event when they've done the same thing so many times? The 40-year-old who's been running all their lives, but then on one day has a cardiac arrest.
Yeah, I mean, that's such a great question, and I think that's an area of a lot of interest, because I think that if we had that kind of level of precision to be able to at least even start to predict some of those events, I think we could be a lot farther along in the care for these patients. I think at this point, though, most of what would mostly be speculation in terms of that. I think there is some evidence, though, around what kind of circumstances. So the way I like to look at, a sudden cardiac arrest during sport is it's a combination of both the substrate. And so by that, I mean the underlying condition. So do you have heart disease? And what is that heart disease? And I think there's starting to be an evolving theory as well, as it may be, do you have multiple forms of heart disease? So is it that you have, hypertrophic cardiomyopathy, and then you develop, inflammation from, viral infection like myocarditis or something along those lines, and maybe that increases it above either of those conditions alone? Or the same would be true if you have, a risk for, long QT syndrome, or arrhythmic risk, and other factors that come on top of that. And sports and exercise, particularly vigorous intensity competitive sports and exercise, does put the body under significant hemodynamic and metabolic stress. We're adapted to deal with that, but at the same time, sometimes there's things that can go wrong. And I think I personally have the opinion that sometimes there's the cases of what's called sudden unexplained death syndrome, where we really don't understand what the cause was, and that's becoming a more and more kind of not frequent, but I guess when in the studies looking at the etiology of sudden cardiac death, it's becoming a larger portion of the pie in more contemporary studies, and to say that there isn't a specific cause that we could identify. And I do think even in healthy individuals, either there's something that we haven't identified yet, or potentially just the circumstances and the stress that the body was under had triggered that arrhythmic event in a certain proportion of patients. Again, that's more speculative, and I think there's still a lot of work to be done in that area, but I do think some of the time the stressors the body are under. And so what I mean by that is that you can have various stress, heat stress. We know that affects the body, and heat stress alone can cause issues and sudden death in very severe circumstances. And the other interesting finding, now this is a little bit more, not necessarily for SADS conditions per se, but is that when sudden cardiac arrests occur during distance events such as marathons, they typically occur towards the end of the event. And so I think that just leans on, so something else is going on during that, and whether or not that is the competition, people pushing themselves through symptoms that they otherwise would have stopped for, or a combination of the fact that they're dehydrated and that there's other metabolic stress going on at that time, and things in those kind of scenarios that have triggered one of those arrhythmic events. But I think it's quite an interesting observation that requires further work to say that when they occur during these events, they tend to occur towards the end. And then other patients, I always, when I counsel my, athletes around, things like, to worry about or to be concerned about that may trigger an event if you have an underlying substrate. So making sure to avoid other triggers, illicit substances, performance enhancing substances, all those kind of things you would go through with most of your athletes, or depending on the condition, avoidance of other drugs that may prolong QT, along those lines, as well as making sure that you avoiding exercising, or at least understanding that exercise in extreme environments, extreme heat, extreme cold, may increase the risk because you're adding an additional metabolic stress on the body in addition to the exercise that you're performing. And so I think we're still not able to say, like, for any individual athlete, okay, which stressors are going to be there, but I think we're starting to understand there's probably a combination of factors, and at some point we maybe have a better sense of, okay, well, certain substrates or certain underlying conditions faced with these kind of additional risk factors are particularly high risk, and then maybe we'll be able to kind of counsel or put in plans in place. And I think one of the kind of examples I really like around responding to events, I know it's a whole nother topic as well, is in Japan, where they've actually put in place, mobile emergency action teams and they focus a little bit more towards where the events occur. And they've had excellent success rates with being able to respond to and resuscitate patients that have cardiac arrest during mass events.
Yeah, as a marathoner myself, I was reading about the Japanese cyclists with AEDs sort of tracking along the marathon. And I think that is one of the very tricky things, and we've talked about the role of the autonomic nervous system in events. We had Dr. Atala talk us a bit about cardiac denervation and things like that. So lots more to learn. Definitely. And great that you've mentioned those important points for our identified patients and our treated patients. We have a rule in our clinic that if you miss your medication, don't go out and do, exercise that day. And you have, if you've been a bit patchy about taking your medications, that is a very high risk situation. It's a conversation we have, especially with some of our teenage patients who are, slowly transitioning to becoming responsible for their own management of their medication. So there's a lot of things you can do once you know you have a SADS condition to make your participation safe. Let's talk a bit about shared decision making, because it's the term has certainly come into prime time in the last few years. You were part of, I think, a nice review about the sort of the science of the process. Just maybe explain, in broad terms for our audience, what are we even talking about? Because I think most people feel like their doctors just tell them what to do, and that's it. It's a one-way street.
Yeah, I think, as you correctly identified there, I think shared decision making is almost better understood in the context of what it's not, or the opposite to it. And so that would be kind of the paternalistic approach, that kind of doctor knows best approach, which is kind of, I would say, not the approach that's recommended across really any area of medicine at this point, but has been a more historic approach to interactions between patients and doctors. And I think there's a power differential that will always exist in terms of knowledge. And so for a lot of the time, patients are coming into an interaction not being the quote expert in the area, but obviously being an expert in themselves and their goals and their wishes. And I think shared decision making takes the role of looking at, okay, well, how do we combine patient autonomy, patient wishes and desires with the expert knowledge and medical management to come to a solution? And it's particularly applicable, or a decision around various treatment. And so it's particularly applicable to the areas where there's a lot of uncertainty. And so I think that's kind of where it started to come into the sports and exercise participation decisions, is there has been a lot of uncertainty and continues to be that. And in the past, from a physician's standpoint, kind of in broad terms, it's sometimes easier to say, okay, well, we're just going to make a binary decision, yes or no. And you fill into, as you pointed out, from older iterations of guidelines, and that's how they were set up. They were saying, okay, well, here's a list of conditions that we think are high risk, And so the decision is a yes or no. If you have this condition, you shouldn't play sports or participate in vigorous intensity exercise. And if you don't, then you should be okay to do so. And for all the reasons we've talked about already, it's kind of shifted away from that. And so the shared decision making is really the understanding that, okay, well, there is, a lot of gray area here. And I think at the end of the day, we may not have a definitive answer in terms of, what the risk is for a specific patient. And I think it's understanding that, patients also have variations in risk tolerance. And so I always like to talk to my patients around, different activities that are at risk, whether or not you have heart disease, such as mountaineering, scuba diving, things along those lines that many people undertake, and kind of assume that risk at baseline, and try to put that in context as best you can with, what you estimate the risk to be within, a specific condition and specific sporting activity. And I think one of the things shared decision making is not, though, is the flip side, which some of the naysayers or people, I guess, that would still advocate for less of a kind of shared decision or more of a paternalistic approach, would be that, patients, that's going to give physicians the ability to say, okay, well, the patient decides. And then in all cases, patients and families, if they're asked around that, will really push to continue to participate. I think that's one of the kind of myths, if you will. And I know you had Dr. Ackerman on the show before, and I think he's always been a big advocate around that, saying that that's really not the case. And I think that's my own clinical experience as well, is I think patients and their families in these situations, they want the knowledge as best they can to understand that. They also want advice from the physician. So I do tell my patients, it's not so much here's your condition. This is, you might be at risk if you continue to play. If I feel that there's a prohibitive or high risk, that's part of the discussion. I think you brought up very good points as well. That also includes things like making sure that they are appropriately managed. So, and they're taking their medications and complying with that. So all these kind of factors go into it. But I think the kind of switch here, if you will, is if you look at it more from a basic principle standpoint, is previously a kind of physician, kind of paternalistic approach. And now the shift more towards, patient autonomy and ability to be involved in decision-making is kind of the key kind of construct from what we're shifting to. The process, though, is, there's no one size, as I think from you alluded to that when we were reviewing the literature in this space, there's no kind of one size fits all approach to this. It looks very different from a practical standpoint from when, you're dealing with a young competitive, a professional athlete that has a lot of external stakeholders and even and internal pressures as well around financial considerations versus someone in their 40s or 50s who is doing this more for recreation, and then is willing to consider other activities and maybe more willing to, not necessarily wanting to go through the whole process, and has a better understanding overall and less of these external pressures. So the kind of shared decision making approach needs to be tailored to the individual, and I think it's really one of the reasons that, or one of that sports cardiology, at least from a clinical care, exists, and one of the areas of expertise that you can lean on or kind of refer to if you're struggling with these conditions or looking for how do I approach my decision around or get more information about this, looking for expertise in sports cardiology and kind of making sure that kind of shared decision-making approach is paramount in the clinicians that you're seeking out advice from.
Yeah, it's certainly, I think it's a very positive development that there is good dialogue, and, your comment that, your 10 or 15 years of training do give you a deeper understanding of the data. The data is so widely available. We're all sort of familiar with, Dr. Google, but really the nuanced interpretation of it is so important in that conversation. Do you sometimes bring in the coach as well? If there's an athlete that's, pretty high, high intensity, and the coach wants to get your clearance? Or is that more of a pediatric phenomenon where there's sort of a permission slip and that?
Yeah, no. So what I would say is, I've personally, and I know there's different approaches to that. the idea of, okay, clearance or signing off on all those pieces, I know it's still kind of asked, or sometimes from an institutional organizational level. I've personally tried to move towards, I'm here to provide guidance on that, and then trying to bring the athlete back into being the one who is making the decision. I know that can be quite challenging, as you pointed out there, because I think particularly in the kind of competitive athlete space, I think that's what makes the competitive athlete a little bit different than the recreational athlete, is that there are these other stakeholders. And so whether that be the coach, there's also sometimes, in the professional world, there's agents, there's other people that want to be engaged with this, that have, differing kind of positions themselves around looking after that patient. And it's a little bit hard to navigate that. I think I always like to have discussions with the patient and their kind of what I call their core team, with their family members really as the initial one. But then if they want to bring in other members, I think that's good for the discussion. I think it's also part of the kind of, if they're deciding to go back, part of one of the main strategies that I'd like to talk about is making sure that you inform the appropriate people of your condition as well to assist with that. So that can actually be helpful. So if there's, a very important coach or a very important person within the organization that they'd like to be involved, we'll include them. But I think at the end of the day, I think the decision should be kind of focused on the athlete and their immediate care team, being their family members, and those, I think, that are with them and maybe outside of the organization. But I think, as you pointed out, it becomes a little bit tricky and can be challenging to kind of determine, who fits within that, and obviously want to respect patients when they, have important people within their life that kind of help them make those type of decisions.
Well, we're at time. This has been a wonderful conversation, and there's so many other areas that we can get into, the return to school, the safety plan, AEDs. So lots more to talk about. And I think a great opportunity, for the Canadian SADS Foundation also to be part of the conversation about these, these difficult decisions that families face. So thank you so much for being here today. It's a pleasure to talk about this stuff. It's, as the participation is so important to our patients, and sometimes, it's a real touch point for the families. The one parent views things one way, the other parent has a different view, the child has a third view, and our job is to somehow bring everybody together and make sure that we're safe, but also thriving. So absolutely great to chat with you this morning.
Well, thank you, Shu, and thank you so much for the opportunity. I hope that this was valuable for the listeners, and then I think just to recognize that sports cardiology exists, and that and like you said, I think there is many people have expertise in these areas, and not to say that you're seeking out, if you're an athlete, seeking out someone that really understands this can be the person you're already seeing, of course. But if you're looking for specific kind of guidance around that, within like decisions on return to play, as there becomes more resources available within the world of sports cardiology, definitely, and for the practitioners on the line as well, consider referrals, as that's what we're interested in seeing. And I think you mentioned at the beginning, and in Solace Row, and so I work at Sports Cardiology BC as well here at UBC Hospital, and so that's kind of one of our main focuses. It's both within clinical care of athletes and highly active persons, research and advocacy on all the fronts that you said as well. And obviously SADS is very much in the advocacy realm as well.
Terrific. All right. Well, thank you so much. Enjoy your last couple of weeks of summer. So yeah, it's such an interesting topic, I think, because it does, it's this dichotomy. We hear, every day that sitting is not good for your health, and, get your 10,000 steps in, or 8,000 might be enough. And yet, not that long ago, people were very much told, don't do any activity, don't get your heart rate up. And there are still, practitioners out there who have not necessarily embraced the emerging data. So, talk to your SADS healthcare provider, talk to your team, and we're really enjoying watching the data develop as we, here at the Canadian SADS Foundation, partnered with so many of the great investigators that we were referring to. So, well, that's it for the show today, and looking forward to coming back to you next month. And we have another great guest lined up, and really appreciate your support. If you do feel like you want to make a contribution to the Canadian SADS Foundation, swing by the website and make a donation. It helps us continue to provide educational material, and hopefully we're moving towards even more educational offerings and more advocacy. I know our executive director, Pam Husband, is hard at work connecting with other organizations and doing lots to make sure that our families and our patients are well looked after. So thanks very much, and we will see you next month.